Welcome everyone, and get ready to learn. Today, we're bringing you a comprehensive, no stones unturned explainer on an incredibly fascinating topic, craniofacial development. We're going to dive deep into exactly how the infant skull develops and what happens when that dynamic, beautifully orchestrated process is disrupted by a condition called craniosynostosis. We've got a lot of ground to cover, so let's jump right in.
Here is our exact roadmap for this explainer. We'll start with normal craniofacial development, move into understanding craniosynostosis, break down the causes and surgical treatments, dive into the detective work of diagnosis, and finally, look at the very real danger of increased intracranial pressure. Section 1. Normal craniofacial development. This is the dynamic blueprint of the growing skull. Okay, so to allow for a rapidly growing brain, a baby's skull isn't just a solid helmet of bone right out of the gate. It has these vital soft spots we call fontanelles, and what's really cool is how their closure happens in this perfectly staggered sequence. At 2 to 3 months of age, both the triangular posterior fontanelle and the small irregular sphenoid fontanelles close right up. By 1 year, the mastoid fontanelles seal, and finally by age 2.5, the anterior fontanelle closes. Now, this anterior one is the absolute largest. It's diamond-shaped and measures a massive 4 by 2.5 centimeters at birth. What's truly fascinating here is the sheer speed of this process. You see, skull growth is largely dictated by the growth of the brain physically pushing outward. In just the first year of life alone, an astounding 90% of adult head size is already achieved. Think about that. By the end of year 2, the bones interlock at the sutures. By age 6, we hit 95% of adult head size. And by age 7, well, cranial vault growth essentially ceases altogether. Any further growth after that point happens purely by accretion and absorption. Now keep in mind, the skull isn't just a static dome that just gets wider. Its actual internal structure evolves over decades. At birth, the skull is unilaminar, meaning it's just a simple single layer of bone. By age 2, the mastoid process begins to form. By the 4th year, we see the appearance of the diploe, that spongy bone tissue sandwiched between the hard outer and inner layers. During the 6th year, mastoid air cells form. And believe it or not, the skull continues to mature all the way up to age 35. That is when the diploe reaches its absolute maximum and diploic veins finally form. Section 2. Understanding craniosynostosis. The bottleneck in brain growth. So, what exactly is craniosynostosis? Originally called craniostenosis, it is simply defined as the premature ossification or early bony fusion of a cranial suture. Basically, those essential expansion joints we just talked about, they turn to solid bone way too early. This incredibly specific number, 0.6, represents the incidence rate per 1,000 live births. So, while it is a very well-known and highly serious condition, it's actually relatively rare. It can occur completely on its own in isolation, but it can also be syndromic or entirely secondary to other conditions. There is a very specific mechanical rule of thumb you need to remember here. Once a suture ossifies prematurely, normal skull growth perpendicular to that suture completely stops. It hits a wall. But because the growing brain still desperately needs room, compensatory growth is forced to proceed parallel to that fused suture. The skull stops growing across the fused line and instead pushes out alongside it. That is exactly what creates the visible and often quite severe deformity. Section 3. Causes and surgical treatment. Let's look at etiologies and interventions. While primary craniosynostosis is usually a prenatal deformity, the secondary culprits fall into 4 distinct categories we absolutely cannot overlook. Let's go point by point. First up, metabolic causes, things like rickets or hyperthyroidism. Second, toxic causes, which includes exposure to drugs like phenytoin, valproate, and methotrexate. Third, hematologic issues, like sickle cell disease or thalassemia. And fourth, structural issues, which actually stem from a lack of brain growth, seen in conditions like microcephaly, lissencephaly, or micropolygyria. Oh, and a quick note, this condition is rarely associated with hydrocephalus, and the idea that craniosynostosis follows CSF shunting remains largely unproven. The stakes we are dealing with here are incredibly high. If multiple sutures are involved, brain growth can be severely, structurally impeded by the unyielding skull. This directly leads to pathologically elevated intracranial pressure, or ICP. Now, you might assume elevated ICP only happens when multiple sutures close up, right? Actually, it occurs in roughly 11% of cases involving just a single stenotic suture. Plus, if the synostosis specifically involves the coronal suture, It can even cause amblyopia, a serious vision development disorder. Because of the severe psychological impacts of a disfiguring deformity, not to mention the direct risk to brain function, the treatment is almost always surgical. A single suture involvement is typically treated with a pretty straightforward linear excision of that specific suture. However, if multiple sutures of the skull base are involved, well, the situation becomes highly complex. You're going to need the combined efforts of both a neurosurgeon and a craniofacial surgeon, and these operations often have to be staged over time. The risks of this kind of major surgery are significant, including substantial blood loss, seizures, and even stroke. We are using these beautifully stylized, watercolor-themed clinical references to break down every single parameter step by step. They highlight the exact foundational differences between normal fontanelle closure and abnormal fusion, underscoring the immense precision required in pediatric medicine to track exactly where normal growth ends and pathology begins. Section 4. Diagnosing the deformity. Time for some medical detective work. The critical first step in this detective work is distinguishing true sutural fusion from simple positional flattening, often playfully referred to as a lazy lambdoid. So how do you actually tell the difference? You use the 6 to 8 week observation rule. Doctors will instruct parents to intentionally keep the infant off the flattened area of their head for 6 to 8 weeks. If it was merely positional, the shape will naturally improve on its own. But if it's true craniosynostosis, it will declare itself by either getting worse or failing to improve at all. But doctors aren't just sitting around waiting. They do a thorough physical exam, literally feeling for clues. They will palpate or deeply feel for a bony prominence or ridge right over the suspected synostotic suture. Now, there's a super fascinating exception here. If it's lambdoidal synostosis, it might actually produce a bony trough instead of a raised prominence. The doctor will also apply gentle, firm thumb pressure on either side of the suture. In a normal, healthy infant skull, there's a slight give, a slight movement. In craniosynostosis, that pressure fails to cause any relative movement of the bones whatsoever. Next up, imaging gives us our first internal clues. Plain skull X-rays will often show a distinct lack of normal lucency, that dark, empty space in the center of the sutures. But doctors have to be really careful here. Sometimes, focal bony spicule formation can literally trick the eye and make the suture look totally normal on an X-ray, or even a CT. That said, the X-ray might also reveal classic signs of increased pressure, like a beaten copper appearance of the skull vault, sutural diastasis, which is the forced separation of the remaining open sutures, and erosion of the sella. Stepping up the imaging to a CT scan gives us a vastly clearer picture. A CT easily demonstrates the overall cranial contour and clearly shows the thickening or ridging at the specific site of synostosis. It's also going to demonstrate if hydrocephalus happens to be present and can show the expansion of the frontal subarachnoid space. Ultimately, though, the absolute gold standard here is the three-dimensional CT. It's simply the best, most comprehensive way to visualize these complex structural abnormalities. In questionable cases, a technetium bone scan maps the biological activity step by step. During the first weeks of life, there's very little isotope uptake by any normal sutures. But if a suture is actively prematurely closing, the scan will show increased activity compared to the normal ones. Once it's completely closed and fully fused, there's no uptake demonstrated at all. Just a couple of other quick diagnostic notes. MRI is usually reserved only for cases with associated intracranial abnormalities, making it generally less helpful than a CT. And be warned, simple measurements like occipitofrontal circumference might appear totally normal, even when a severe deformity exists. As illustrated by our watercolor-themed diagnostic breakdowns, this rigorous point-by-point criteria, from the physical thumb pressure exam all the way to advanced 3D imaging, ensures no critical detail is missed before moving to surgery. Every single measurement is a vital piece of this complex puzzle. Section 5. The danger of increased ICP. This is the ultimate risk to the brain. If the skull cannot expand, the pressure rapidly rises inside the vault. Evidence of this increased ICP in newborns includes the radiographic signs we just mentioned on X-rays or CTs. But crucially, you will see a total failure of calvario growth. In a normal, non-synostotic skull, increased ICP usually just causes macrocrania, or an abnormally large head, because the sutures simply stretch apart to make room. But here, the synostosis is the exact thing causing both the dangerously increased pressure and the lack of skull growth. Clinically, this extreme pressure leads to papilledema, swelling of the optic disc, and ultimately devastating developmental delay. I want to leave you with this final thought to ponder. How does the extraordinary, relentless adaptability of a growing brain survive the ultimate structural bottleneck? It is a profound testament to the incredible resilience of human biology and a really stark reminder of the absolute precision and care required from modern medicine to step in, release that immense pressure, and set the brain free to grow. Thank you so much for joining me for this explainer. Keep learning, stay curious, and I'll see you next time.